You're watching Empowering Neurodivergent Registrars, produced by GP Supervision Australia and presented by Dr. Katie Williamson. We would like to begin by acknowledging the traditional custodians of the land on which this recording was produced and pay our respects to their elders, past, present, future, and their families.
Welcome. Thanks for coming along. I am really excited to be able to host on such an important topic. I'll introduce Katie a bit more formally in a second, but I heard Katie speak at the GPME meeting in June in the Gold Coast this year. She was the keynote speaker and ran a workshop on neurodiversity and identifying and supporting neurodiverse registrars. And I must say, for an educator working in GP training for over 2 decades, I guess I've always been aware of registrars who may have neurodivergent traits or indeed have diagnoses of ADHD or autism. But so commonly, I think it's something that we're sort of concerned or worried or thinking might be the case with the registrar, particularly those who are struggling. And it just doesn't get addressed as well as it might, and the registrar not supported as well as they might. I would like to introduce Katie Williamson, who, as I say, is from Cairns. And Katie's worked as a GP and rural generalist in remote and regional communities across Australia. She's a very more recent, but a colleague of mine from the University of Sydney. Medical educator, lectured for James Cook, University of Wollongong and Flinders, and she's supervised registrars since she was a new fellow herself, travels across remote Queensland, providing clinical services. That's the formal stuff, Katie, but I really like the other part of your bio, and that's that you're regarded by your patients for somebody who approaches their health with curiosity and compassion. I think, gosh, that is a wonderful trait to be recognised by your patients. You're a coach, you motivate your patients, empower them to make positive changes. And most importantly for the topic tonight, you have a specific interest in autism, ADHD diagnosis and management, and you're a member of the special interest group for the RACGP and also the Australasian ADHD Professionals Association. And you're very good and a fan of empowering people. And thank you so much for coming along. I'm really looking forward to this. I'll hand over, but thanks for your time.
Thanks so much, Simon. So we'll talk about how these neurodevelopmental disorders can affect our GP registrars and look at not just the challenges, but take a bit of a strengths-based approach as well. We'll understand about how these conditions can affect wellbeing and how we can enhance the wellbeing of these registrars and look at more practical applications of reasonable accommodations in the practice and even, with college exams as well, and perhaps formulate a more personalised approach to mentoring and coaching our neurodivergent registrars. So I'll start with this symbol on the left here is the internationally recognised symbol for neurodiversity. It was actually an Australian sociologist, Judy Singer, in 1999, published the term neurodiversity first, and it embraces the more strengths-based approach to the conditions of ADHD and autism and counteracting the dialogue of these conditions being just disorders. The term neurodivergent was not specifically used by Springer, but it is probably the better grammatical description when we're talking about those that diverge from neurotypical. There is the risk of neurodivergent implying that there is a norm from which we're diverging from, which has potential problems itself, but probably the best terms that we've got at the moment. But there's the increasing drive really culturally to promote the associated strengths of these conditions. Social media is branding superpowers of ADHD and autism, but I think we need to be careful not to minimise the deficits that do come with the disorders as well, because neurodivergent people can certainly suffer without appropriate support. I'm an autistic doctor myself, which prompted me to develop a special interest in this area. I've got family members with various neurodiverse conditions. I don't have ADHD, but it is said that neurodiverse people find their tribe. And I work in a private practice in Cairns as well as working remotely. And in my private practice, I'm right near the hospital. I do advertise that I have an interest in autism and ADHD. So I do see subsequently a lot of neurodivergent health professionals across all career stages, doctors, other hospital staff as well. I was a lead medical educator in far north Queensland as well for a number of years. And I think I found that a lot of the registrars that I was called on to help support often have neurodiverse traits of some kind. Some of them may actually disclose a diagnosis, some disclose a concern, some may go on to receive a diagnosis, others continue through their training blissfully unaware. One of my other special interests is gender dysphoria, and I have a lot of transgender patients. I think it fits under the umbrella. My transgender patients often are not comfortable being under the sexual health kind of rainbow and seem to find their space here as well, with a lot of crossover with other neurodivergent conditions. So the prevalence, if we look at just autism and ADHD, the two most common neurodivergent conditions, in the general population, 1% of Australians are autistic, about 4% of Australians under the age of 45 have ADHD. The prevalence of autism is increasing, and that's obviously thought to be not just due to actual growing numbers of autistic people, but increase in diagnosis in the sensitivity of the testing. Both autism and ADHD are more common in males than females. That is starting to tip with more females being diagnosed. And again, that's thought to be probably due to diagnostic criteria changing and recognising the presentation of these conditions being different depending on the person's gender and their social upbringing. Now, there's a lot of myths and stigma around ADHD and autism. So I'm a member of Autistic Doctors International, and they're a UK-based organisation but have a global membership. They've done a lot of research in this space, and they revealed in a survey that of their doctors that actually have a formal ASD diagnosis, over 30% don't feel comfortable to reveal that in the workplace. So this is slipping through silent because of the stigma around it. And the same could be said of ADHD as well. My doctor patients tell me that they get told these sorts of things all the time. You couldn't be a doctor if you have ADHD, and really minimises, I think, how much people with these conditions can work harder, they mask, and underneath can be really struggling to get through training to get to where they are. I'll talk a bit about empathy and autism later, and this idea that someone looks autistic, whether that's popular culture that can be blamed for that or not, but it can be a challenge for doctors to even think that they might have ADHD or autism. There was a question about this as well. Does RACGP collaborate with other colleges in this issue? There seems to be a lot of fear amongst hospital-based registrars of being labelled with a diagnosis and a sense that the workplace would never make any accommodations. And that is sad. I agree. That's what I hear as well. And legally, the workplace does have to make accommodations for these conditions. But overcoming the stigma is the challenge, really. So Mary Colley was a founder of DANDA, a UK-based developmental adult neurodiversity association. And this beautiful quote from Mary, I think, it describes that we really do need a diverse workforce to serve a diverse population of patients in healthcare settings. And Simon and I were talking earlier about, how often patients find their doctor they connect with, and neurodivergent people do find each other. So I think we need to support our doctors to create that diverse collection of caregivers that we need. Simon also mentioned earlier that are we only just realising that we need to support these students, these registrars? And I think that that's right. There was a 2021 study of medical educators in Australia, and it showed only 16% had ever adopted their teaching approaches to cater for neurodivergent registrars. It's not uncommon for this to have not been considered by a medical educator or a supervisor before. And I think that we're all seeking to change that. There's been a lot of research published in this in the last few years about autism and ADHD in doctors and in medical education. So there was at least 12 current less than 4-year-old studies that I could find on this, with not a lot before that. So it's a booming area. I think we are going to see more doctors with ADHD, and that is because the classroom now looks very different to the classroom that I was in when I was at high school and getting my grades up to get into university and then study at university. My son's classroom, they can choose to go and sit on a beanbag with their headphones on to type their essay on a laptop, and he's only in primary school. It's very different to when I was at school, and many of you as supervisors would have been at school. And I think because of that, we're going to see students thriving academically that might otherwise not have, and get a more diverse medical workforce in the end, hopefully. I'll just cover the basics of ADHD. Really probably needs to be renamed, because all of my patients, when I mention this to them, that the person with ADHD doesn't have a deficit of attention. They've got lots of attention. It just is not regulated and where they need it to be at that particular point in time. So if we think about it as a disorder of dysregulation, and the basics being of the attention and cognition and the physical and exertional, we might label these as inattentive type or hyperactive type, or a mix of both combined. But I think we need to not forget the emotional and the social aspect of ADHD. So the emotional dysregulation, the social impulsiveness, and put all together, this disorder of dysregulation. And if we're looking at a registrar as a supervisor and thinking there's a problem with regulation here somewhere, then maybe we need to be thinking in the back of our mind, is this ADHD? Someone with ADHD, when I was a medical educator, I thought of them as being a nightmare for our admin team, but actually really endearing for our medical educators. So they can appear chaotic and disorganised. There's a number of doctors I've spoken to with ADHD who have at some point in their careers forgot to register for their APRA. And, they can be risk takers, impulsive and talkative, frequent exam failures. You wonder how someone can actually get through high school, university, be highly academic, and then just keep failing exams as a GP. It just doesn't quite make sense. They are more prone to mental health disorders and substance abuse disorders as well, just as a product of the minority stress model, where the stress of having to function in a world that's not quite created for them can lead to poor mental health. Looking at the neurodiverse strengths-based approach, though, these two sides of the same coin, a distracted registrar can also be a dreamer, be creative, an idea machine. That poor impulse control, risk-taking and being comfortable with risk is an important part of general practice. I think we all see many of our fresh registrars struggling with that, having some level of accepting risk, letting the patient go out the door without a diagnosis. So that can be quite a strength for a registrar in general practice. And that fidgety, hyperactive can be energetic and get a lot done. So when appropriately supported, our ADHD doctors, they have cognitive dynamism, they're divergent, creative problem solvers, they're courageous, they manage uncertainty well. There was a theory I read some years ago that ADHD was higher in Australians than other Western countries, and the paper discussed about whether that was due to our diagnostic model or whether our schools were picking up more ADHD kids. But one of the theories they proposed was that the genetics of our immigrants into Australia are more likely to be novelty-seeking risk takers. And it just sort of planted a seed for me, having worked a lot rurally, whether this also translates a little to our rural generalists, where that kind of courageous practice is an absolute asset to rural generalism. ADHD people often are the social ones too, and obviously if they've got through to this point in their training, there's a level of resilience and persistence, not because of their ADHD, but with it to get through to where they are. With consent, I published this quote. So Jess Loughlin's an Australian GP, and I asked a group of doctors with ADHD what makes them a good doctor. Jess said that her ability to hyperfocus, her intuition and her attention variability makes her a good GP. And I hadn't heard of this term attention variability before. And she said, oh, it's being able to see the big picture with lots of detail really quick and focusing on what's important. So I said, so kind of like a Where's Wally cartoon? She said, exactly like a Where's Wally cartoon. So I think if you can imagine your diagnostic dilemma walking into your general practice, your ADHD doctor is the one that's going to help with that creative divergent thinking and then focusing down on what's important. Other responses when I surveyed ADHD doctors was that they felt that being able to identify and connect with other neurodivergents in their patients, they felt was a strength as well. Again, that sort of finding your tribe.
Just a couple of comments. So John Kramer, who I imagine is a colleague of yours, he's commented that the convicts brought some ADHD along as well. So there you go. That's way back to the First Fleet.
I think the convicts and also even just, refugees, immigrants in general, John, and it fits, I think, with rural generalism too. But I mean, this is all a theory. Most of what I'm presenting tonight is evidence-based, but that's my theory.
The Williamson theory of
that's right.
generalism. And Ern's asked about something that I don't think I know a whole lot about, and I don't know if it fits a little bit more with what you're about to talk about, but the concepts of 2E and double empathy and how that might fit in the conversation.
I'll get on to empathy as I progress through the autism, but it certainly does apply to ADHD as well, yeah.
And this isn't meant to sound flippant, but I wonder whether a Where's Wally cartoon might be an interesting diagnostic test for somebody who can get rid of the chaff and go straight for yep, there he is there. I wonder if anyone's actually spotted Wally there. He's somewhere there, I'm sure.
Well, I mean, one of my patients said this week, and so I see, just to put it into context, probably about 8 patients per day in my clinic. Of the 30 that I see have a neurodiverse diagnosis. Yeah. So that's kind of the volume of patients I'm seeing. So this week, one of my patients who's very early in her journey in treatment for ADHD, she's a health professional, and she said the medication makes it so much easier to function in the workplace, but she said it takes away a part of me. And she said, and I don't like that bit taken away. So I talked to her about the Where's Wally cartoon, and I said, from what I can understand, the medication focuses on Wally, but you kind of miss the fun of the cartoon. And she said, absolutely. She goes, I want my Where's Wally cartoon sometimes. So yeah, I think it's a good analogy. So just with autism, if we can get away from thinking that there's mild autism and severe autism, or even low functioning, high functioning, which is a bit offensive really, loaded with judgment. Low support, high support is probably preferred in terms of an NDIS frame, but just autistic is fine as a description. If we look at that image on the left, the autistic spectrum looks more like this. So an autistic person may have very strong language skills, very poor executive function, or very sensory averse, sensory sensitive, and poor motor skills. It's really a spectrum of individual strengths and deficits. And so there is not one model for supporting the autistic person either. Temple Grand, if you don't know Temple, she's a big American autism advocate. As a child, she was almost non-verbal till about the age of 13, and she's now a professor, a lecturer and researcher in animal science at Colorado State Uni. I think this quote from Temple's is fantastic because, when you kind of take away all the social demands of being neurotypical, autistic people do get a lot done. And research has proven that. There was a JP Chase Morgan Bank study that showed that autistic people were, when properly supported, were 50 to 200% more productive than their non-autistic peers. But, the getting into medical school part can be kind of easy if you're autistic with, science-based exams, and even getting through medical school can go unchallenged. And then you get into the high language-based communication environment of hospitals and medical practices where difficulties can start to arise. If you're thinking your registrar there's some sort of communication issue going on here, we're just not getting each other, or that there are problems with the staff, that then maybe autism should be there on your radar. The masking refers to the skill of appearing non-autistic, and the unmasking can go off at the end of the day from sheer exhaustion of having to mask all day. Because autistic people lack the understanding of social nuances and graces, they are at risk of abuse as well. They can misunderstand hierarchy and essentially get a bit lost in terms of their place in the world, which can lead to anxiety and depression. So anxiety and depression affect 80% of autistic people over their lifetime. So it's very high. A recent survey through Autistic Doctors International revealed that 77% had considered suicide at some stage, and 24% had actually attempted suicide. So this is just autistic doctors. Whilst 80% had worked with colleagues whom they suspected had autism, only 29% felt they couldn't disclose their diagnosis in the workplace. So it's a stigmatized, difficult place for many doctors to be in. There's another quote that I like that I've noticed in some of our struggling registrars as well, is that autistic people have a tendency to talk truth to power. So that combination of misunderstanding hierarchy and also rule followers, they can end up being trouble in the workplace. For those of you that know Hannah Gadsby, she's an Australian comedian who had an autism diagnosis as an adult. And she articulates her experience just beautifully. And Hannah had depression and anxiety for years. And as she says, it turns out I was depressed and anxious because I couldn't sort my life out like a normal person, not the other way around. We see our patients with depression and anxiety and they can't get off the couch. What came first? And I think that's where, Simon, kindly you described me as having curiosity and compassion. And I think this is where I generally start with my patients and even registrars, is what's going on, how can we help you? If this is depression and anxiety, why has nothing else worked? What's underneath it, So I think given that doctors and dentists as well have consistently been found to have the highest suicide rates in Australia, the presence of autism in a doctor is something that could be very important to identify, given there's the high suicide rates amongst autistic people. So this is a little bit about empathy. So there's two types of empathy. Effective empathy is emotional empathy, the ability to feel how someone could be feeling, and it's associated with the limbic system. The other type of empathy, cognitive empathy, is the thinking kind of empathy, the perspective taking and understanding of why someone's behavior or conversation may go how it goes. And that's a separate part of the brain entirely, in the prefrontal cortex. So people with autism have a disorder of cognitive empathy rather than effective empathy. And it's thought actually that the effective empathy then becomes overdeveloped almost as a compensation for the lack of cognitive empathy. And that's where we see our autistic people really deeply connecting with other humans on an emotional level and other animals as well. I see a lot of patients who the autistic animal lover, like Temple Grandin, I suppose, is very common experience. So psychopathy is a disorder of effective empathy, of not actually understanding another being's emotions, So to suggest an autistic person lacks empathy is actually somewhat offensive. So if we look at Autistic Doctors International, the majority in that group are GPs, followed by psychiatrists. So that challenges the traditional view that autistic doctors are more likely to be in sort of non-relational specialties. Even given, if we take into account that these two specialties, they might be more aware of neurodiversity as a concept, still the nature of their work in general practice and in psychiatry challenges the myth that autistic people lack empathy. That is just not true. So autistic people that have strengths quite often, going back to, again, it's a spectrum, everyone different, but strengths in rules, ethics and justice, heightened senses and attention to detail, deeply empathetic, highly productive and tolerant of diversity. So if this is not yet sounding like the perfect GP, we'll get there. But if we think of the autistic boom in the 80s and 90s in the US Silicon Valley, where it was the epicenter of technology and innovation, where we had the children of Google and Adobe and Amazon and Cisco contributing to this hotspot of autism. So, but in addition to these sort of technology environments, other areas that autistic people thrive is academia, medicine, in doctors, dentists and engineers. So Becky Ackroyd's a UK GP, and her response to the question, why do autistic people make good doctors? She wrote this. Essentially, in a combination of being excellent diagnosticians, managers of complex chronic medical conditions, and being deeply empathetic. How do we raise the topic? We may be thinking about this in our registrar as a supervisor. How do we raise this? So keeping in our mind, these are stigmatised conditions, so a compassionate approach is required. They may appear to us as a doctor in difficulty, or we may see their executive dysfunction. It could be supervisor or other practice staff concerns, even patient complaints, frequent exam failures. The multi-source feedback report can be very telling. And also this sort of anxiety. Does this doctor have anxiety? And I can tell you, if being a neurodivergent person in a neurotypical world can be very anxiety provoking at times, particularly when you're not understanding the rules in the new environment. So if we more broadly think of autism as a difference in communication and ADHD as a difference in thinking and regulating, you could say to your registrar something along the lines of, you're obviously intelligent and compassionate, or you wouldn't be here. Is the reason why you keep failing your exams, is there some sort of an underlying learning disorder, do you think? So helping them identify the issue can then help create the support plan. Probably the way not to do it, another Hannah Gadsby quote, because I love her so much, something that I have to reel back is that tendency to say, hey, you've got ADHD, and just lumping that on someone. So just exploring it sensitively as picking out the concerns that the particular registrar has, or if you're getting comments from other staff members, looking at the symptoms rather than making the diagnosis, because they're our registrars, they're not our patients. So if we look at how we can support these registrars, there's so many places across their training journey that they may need support. So obviously in the GP practice, there could be reasonable accommodations in the workplace, part-time work, flexible hours, that kind of thing. And the social and emotional support that you as supervisors can give to your registrars is absolutely important. The training program requirements, particularly ACRM, I find can be really challenging for neurodivergent registrars. There's so many tasks to organise and so many timeframes to get it all done in, that actually supporting these registrars with a sort of a project plan and deadlines and some practical tips can be really useful. In our training environments, we've also got small group learning that happens, and if a registrar has a diagnosed condition, then perhaps mentioning that to their medical educators can be useful as well. It's just so that workshops and teaching and learning environments can be adjusted accordingly. There are professional assessment and recommendation resources that I recommend to my doctor patients. So there's psychologists and job coaching and accredited ADHD coaches can all be, really useful resources to help develop a personalised plan and to apply for things like college exam adjustments. So when it comes to college exams, the college has been quite firm that everyone will sit the same exam, but things like additional time or breaks can be accommodated for. In terms of support groups, I've mentioned Autistic Doctors International, the RACGP specific interest group in neurodiversity, in which John Kramer's the chair, is absolutely littered with neurodivergent doctors. So even joining them to further your knowledge about neurodiversity is worthwhile. ADHD Coaches Australasia, if you put that into a search engine, that comes up with the accredited ADHD coaches. So it's ADHD Coaches Australasia. We'll come up with hundreds of nationwide ADHD coaches. One tool that I found has really changed my practice is using AI scribing software. I can touch type and look at a patient in the eye and continue touch typing. I've always been able to touch type. So I didn't think AI scribing software would make that much of a difference to my professional environment, but it absolutely has. I just can't tell you how much more connected I feel by taking my hands off the keyboard, even though I'm still engaged with eye contact with the patient. It's just a different kind of connection. So Dr. Annabelle Bailey published a table in 2023 about ADHD amongst medical students. I've adjusted it to make it a little more registrar applicable about what particular features of ADHD in the workplace could look like and then what you could do in practice. So if you've got teaching sessions with your registrar and it looks like they're daydreaming, they probably aren't. They've probably got some attention to you, but also attention elsewhere, that dysregulation of attention. But giving them a clear and frequent learning expectations, not only over the term, but even over a teaching session. So letting them know we're going to spend 15 minutes talking about your cases that you've presented, and then I'm going to give you 15 minutes on this. It really can help to keep them engaged in a session. And also using a variety of teaching modalities. So I had a registrar with ADHD who loved listening to podcasts while he was doing his woodworking, and that for him was a much better study technique than reading. And, if we look at GPSA's Study Smarter, Not Harder, that Simon developed about 6 months ago, Simon, there's lots of ideas, different ideas that you can recommend for your registrars in terms of study and teaching tools. In terms of difficulty completing tasks, it can be a challenge for registrars getting distracted and struggling to refocus. So that registrar might need additional breaks in the day and prompts to make a cup of tea, have a toilet break, do your emails in this spot, you look at your instant messages in this spot. I've certainly had complaints of some registrars just never even responding to their instant messages that the reception staff are sending through to them, and it's just been too much and too overwhelming for them. So taking away all those distractions and giving them an allocated time in which to do them can be quite helpful. Just personal disorganisation, executive dysfunction, prioritising tasks and time. For many of our registrars, we just accept that they can do this, but acting as a mentor and realising that this person might need some help with general life admin, do they have a cleaner? Do they need a babysitter? They may have just moved to your area to take on the role, and life could be completely chaotic. I had a registrar with ADHD who was constantly late for work, and it was just because it just coincided with school drop-off, and it just, she was too scared to say anything. But once we realised that, we could accommodate for that easily. So away from the cognitive and more on the physical, hyperactivity, impulsivity, constant fidgeting can be agitating to patients. Patients think that the person's not concentrating or not giving them the attention they need. So putting them away from the waiting room and giving them a short walk to go and grab every patient can be helpful. But even suggesting things like fidget jewelry, there's rings that you can get that, you spin the beads around so that they're not fiddling with their clothing or something else. Talkativeness, we see this often in the small group learning as medical educators, but incorporating movement into learning, like considering if you're a supervisor, instead of having a sit down for an hour in a room with your registrar, having a lunchtime walk and talk for a case discussion can be a great alternative. The creativity, I mentioned that as a strength for doctors and particularly of GPs to have that innovative brainstorming and problem solving, but it can also lead, particularly to early stage registrars, to an overwhelming list of differential diagnosis and over ordering of investigations, not being able to narrow it down. It can also, again, in small group learning, mean that they can dominate group sessions. So helping them with their clinical reasoning, encouraging that big ideas, but helping them to narrow it down, and also facilitating discussions to make sure that if you've got a couple of registrars and one tends to be dominating, then tasking them, flipping the classroom, getting them to go away and prepare something and bring it in so that they've both got equal floor time. This autistic space model, it was developed by Autistic Doctors International, and I use this in my practice regularly. So particularly for new diagnosis where they want to develop a workplace support plan, And along with my AI software, I can talk through this with the registrar, find out which particular issues they're having trouble with, and then I can ask my AI software to create a workplace support plan incorporating the SPACE framework, and my AI software generates a 2-page document. It's fantastic. So keeping in mind that spectrum that we talked about, where every autistic person is different, I start by going down this on the right-hand side, the sensory predictability, acceptance, and so on. So I ask them about, is there any particularly sensory troubles at work? Thinking of things like lighting, sound, smells, noisy air conditioning unit, that kind of thing. And we talk about sensory things in the workplace. Predictability, which we mentioned before, about actually knowing what's going to be happening over the day is really important. I had a theatre nurse telling me that when she gets to work and she's ready to do an orthopedic list, and then all of a sudden they put her onto a dental list, she said, that's my whole day gone. Like I just can't cope with it. So we talked about her boss text messaging her in the morning, possibly, if they're going to change her list, so that she's at least just got a few minutes to kind of prepare for that. Acceptance refers to that stigma. So creating a workplace where people aren't speaking negatively or mocking neurodivergent people is really important. One doctor was telling me that her registrar, she felt ridiculed her on a ward round by saying, did you not have your meds today? And I think, as with any disability, it's not acceptable. The status that we walk past is that we accept. So pulling people up on that kind of comments. Communication for autistic people, some really prefer a written communication over sitting down and having a meeting, but not always. So putting in, ideas around how this person likes to be communicated, follow up with an email, for example. And empathy. So when I developed this plan with my patient, a theatre nurse recently, she was saying that they had a case where the patient died on the operating table, and the team leader said, oh, look, the coroner's going to be okay with this, and then let's move on. And she said, I just was so shocked. I felt like I just couldn't understand how she could speak that way so coldly about someone who'd just died. And she said she took that home and had trouble sleeping that night over the whole experience, that deep empathy that she felt for the patient in front of her. Along the bottom, the physical, the processing, and the emotional, these are just further prompts to think about things like the physical environment, the processing, like the time of day, pacing throughout the day, part-time work might be appropriate, emotional, clear communication expectations, and scheduling time to debrief. For our registrars in general practice, it may be that mentoring role of offering out-of-hours support when they need it for, if they've had an emotionally taxing day. Accommodation for exams, the stamps exams in particular. In my experience, we've developed plans, applications for registrars, and the colleges seem to be quite okay with additional time, breaks in the exam, toilet breaks, and opportunities to ask additional questions as well when the question is given to them at the exam, for those practical, like the stamps exam. And in terms of managing the strict college rules, this is where I think thorough educational psychology assessments and recommendations are really valuable. The educational psychologists' reports that I've seen can, be detailed 10 to 15 pages long. ADPA has its own little box here, is from ADPA, the Australian ADHD Professionals Association. If you just search their educational adjustments document, this has sort of come up as their university recommendations. So you can talk those through with your registrar about what they think they might need. And also not forgetting comorbid conditions. So under the umbrella, things like dyslexia and tics can also affect our neurodivergent conditions of ADHD and autism. Anxiety can be frequently a comorbid condition, and this trauma shame cycle. So one registrar was saying to me that she's failed her stamps exam once, and she said, going into the exam again, like getting prepared for it, she said, I just feel like it's another opportunity for them to fail me again. And so I talked to her about, it's also another opportunity for her to prove herself the great doctor she is. So recommending psychological support just for this, addressing this chronic sort of trauma shame cycle that can come from undiagnosed neurodivergent conditions.
Some, practice suggestions for body doubling, which is something I must say I'm unfamiliar with.
Body doubling, I'll just share what it's been described to me as. So a doctor was telling me that she has a tendency to just procrastinate tasks, absolutely. And by just having someone else in the room doing their own work, she gets her work done. And there's body doubling websites, so you can just have a Zoom meeting with someone on the other side of the world that you don't know, who will sit there in your Zoom meeting with you and do their work while you do your work. So that's, yeah.
No, that's fabulous. So there was interestingly, Katie and I were talking very much around neurodiversity in registrars, but of course registrars become GPs who become supervisors, and of course there's likely to be a similar distribution in our supervisor population. And there's just one comment about what about supervisors. So I guess for me this is a very useful educational session to view, perhaps for those who may be undiagnosed themselves and maybe want further information or understanding. Have you come across that much, Katie, in more established GPs, supervisors?
Yeah, particularly I think when they get their children diagnosed, seems to be the point where they say, oh, this is genetic. So for ADHD coaches are great. I use the website of FNQ ADHD. She's a local coach in Cairns, and she's got this really nice kind of pictogram of things that she can help people with ADHD with. Exam preparation, workplace communication, things like that. And when I show that to my ADHD patients, they kind of go, oh God, where am I going to start? I want to do it all, So ADHD coaches aren't approaching it from a mental health perspective. They really are coaching often with lived experience. So they're a great resource.
So Katie's written this, and I think it's appropriately a bit of a story here. So I'll let you read it to yourself and then we'll maybe discuss it.
I'd like to try and approach this with the KFP language, if we can, and ask you what you think the key features of the problem here are.
We've got a supervisor who feels she's got some experience of a registrar and difficulty. We've got a registrar who has switched from one training program to another, which I always think is an interesting thing to explore. There are issues in the practice. She's potentially alienating herself, or other staff are finding her behaviour somewhat difficult, and it is causing some consternation, staff getting upset. And interestingly, she's quite tearful and seems quite crushed about the negative feedback. So maybe a disconnect between what the behaviour that's being exhibited and an understanding of why that might cause some challenges. I guess for me, Katie, I was very impressed with these couple of case studies you put together, because they're very, very illustrative of the sorts of issues we see as educators, we see as supervisors. What about yourself? What are the big key sort of features for that for you?
So for me, Simon, what's highlighted here for me is this a communication problem? And so if we think back to when I was describing the autism and ADHD, where we think of autism as being a disorder of communication and ADHD being one of dysregulation. So I'm not diagnosing Andrea, but a communication problem is a flag. There also seems to be some sort of misunderstanding of hierarchy and her role, and the nurse is saying she's bossy, she's demanding. She's also showing some leadership roles, which the other supervisors feel is outside of her role. But on the other hand, she's also seems quite efficient. She's knowledgeable, probably, having come from that physician's training. She's academic, interested in teaching, and this feeling crushed and teary. There's a little bit of trauma there from previous experiences, I think. So all of those that word salad, to me, I'm thinking is autism spectrum disorder.
Interesting, a couple of people have posed rejection sensitivity disorder or dysphoria as a possible element of this. I imagine, Katie, this case comes from a bit of an amalgam of experience of your own, of seeing registrars as a supervisor and understanding some of the
Yeah.
issues?
Yeah. I've de-identified this by kind of throwing together details of a few different registrars. So this isn't about one particular person, but yeah, as a supervisor and as a medical educator, these registrars, I talked about sort of having trouble in the workplace. That can be a prompt to change career paths sometimes. But how we might support Andrea, obviously very sensitively, I think, emotional support, a compassionate approach, and teasing out with her, well, how is she feeling about all these things, and
Yep.
where does she think it might be going wrong, and can we provide some clearer expectations about her role in the practice? We could say that maybe her orientation wasn't thorough enough, and orientation needs to be tailored to the individual. We might have expected that Andrea would just know where she fitted in at the practice, and that might have been an unreasonable expectation.
I think this is really highlighting some of the issues and bringing together a lot of what you've spoken about. So case 2, I'll just invite you to read this last case. I must say, I've spent a lot of time in my medical career thinking about overdiagnosis, non-rational testing, and maybe neurodivergence isn't something I've ever considered as being a possible element of that. So is that here, difficulty in clinical reasoning, running late, all those sorts of things. Lack of focus, ADHD traits, mix of ASD, I wonder how he's feeling. Time blindness, which again is a term that I've only recently come across, but you talked to me about earlier, Katie, and one I think that is a good part of the vocabulary as well.
Yeah, so this registrar, again, just a mix of a few registrars, but one in particular, he would be working on his car engine all through the night, and actually with time blindness, only realised what time of day it was when the sun started coming up, and he rushed into work, in his overalls. And so that's, example of time blindness. He got just so focused on the task at hand. But serious disorders not to be missed. Of course, there's mental health and drug and alcohol potential differential diagnoses in this problem, with the presentation. So, sensitive, compassionate inquiries about his well-being. He's been open and very chatty to you before. So the how are you going kind of approach, I think, would be a good one here. The other thing I think that stood out here for me is Mark's 34 years old, which always makes me wonder what kind of an interesting life have they had before. And, one of the registrars that this reminds me of was actually a commercial fisherman for part of his life before he started medicine. Just some really amazing, interesting lives that people with ADHD can have because of that combination of novelty seeking and risk taking and adventure. So I think if we get to know Mark a little bit more, try and tease out that we're not missing a mental health or a drug and alcohol disorder here, and then maybe focus on the symptoms. Are you having trouble getting organised and managing your time? What can we do to help with that?
Comments around the need to think about bipolar disorder and, as you've said, Katie, serious mental health disorders. So very, very appropriate.
And I've got a whole list of references. These are probably the key ones I found most useful.
Yeah, and so Katie's very kindly agreed to develop one of our GPSA how-to resources. So this is how to empower your neurodivergent registrar, importantly to identify but also to support them in the practice as a supervisor. Big thank yous, Katie, for your time, but much, much more than that, your expertise, your lived experience, your really, really clear overview of this really important topic for us as medical educators and supervisors. Thank you so very much. All the best. Bye-bye.
Thanks, everyone.
Thanks for watching. We'd love your feedback. Please comment or subscribe to our YouTube channel for updates on new videos. If you'd like to ask a question or suggest a topic, you can contact us via our website at gpsa.org.au. GP Supervision Australia is supported by funding from the Australian Government under the Australian General Practice Training Program.